My name is Sean Fitzgerald, and I'm speaking to you today from Jasper. I'd like to begin today's meeting by acknowledging that the College of Physiotherapists of Alberta offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many live healthy lives on this land long before settlers arrived. With that, we commit ourselves to helping move people forward in their journey towards a good life and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today and encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. It is my pleasure today to welcome April Gamble, who joins us from the Kurdistan region of Iraq. April is a licensed physical therapist that had earned their Doctor of Physical Therapy in Michigan. April has been living and working full-time in the Kurdistan region of Iraq since 2017, and previously in Jordan and China. They have almost 10 years of experience in community-driven efforts to develop equitable and trauma-informed rehabilitation services with an emphasis on persistent pain, mental health, cancer, trauma-focused, and interdisciplinary rehabilitation. I'd like to welcome April, and April, I'll hand this presentation over to you.
Thank you, Sean. I'm very excited to be with you all today. And as Sean shared, we're talking about applying a trauma-informed approach in physiotherapy. You can see on the screen here our learning objectives. So as we will be talking today, it's really the aim is to increase your awareness of what is a trauma-informed approach, why it's important in physiotherapy, and then also give you some foundational knowledge and I believe I am back, so I will share that you can see the learning objectives on the screen here, and we will be talking about trauma today, as well as suicide, traumatic experiences, and some of these topics can be activating for people or triggering, so please do take care of yourself, and if at any point you feel overwhelmed, reach out to your social support system for that. So I am coming to you from the Kurdistan region of Iraq. You can see it highlighted there in green. And a lot of what I'm talking about today is based on my experience with working with different communities affected by trauma in this region. And I will be doing a land acknowledgement as I am on Kurdistan land. So I recognize that Kurdistan is seized and divided land of Nataway Kurd, or the Kurdish nation. Nataway Kurd encompasses about 50 million people that are without a country, that are stateless. We pay our respect to elders, both past, present, and emerging, of Indigenous people that have stewarded this land throughout generations. Those of us that are settlers, like myself, are grateful to have the opportunity to gather, work, and live on this land. We will now have a moment of silence for the pure souls of martyrs, for those that have died defending the land and freedom of Nataway Kurd. So before we kind of dive into some of the theoretical background, I'll share a little bit about myself so you understand the experience and who I am that I'm bringing in to the session today. So the way I describe my work as a physiotherapist is working alongside communities to create justice-centered opportunities for health and functioning. And a lot of what I do involves education, clinical supervision, and program development. And I have different fields of experience, including mental health, modern pain science, trauma-focused physiotherapy, and working with survivors of torture and war trauma. And so also, though, it's important for me to share a little bit about who I am personally, because we bring our values and our histories and our legacies into the work. So I was born and raised in Michigan as a descendant of European immigrants. I respectfully acknowledge that my birthplace is these territories are Anishinaabe. The wealth, power, and advantages that I experience, including where I now live in Kurdistan, Iraq, are the result of colonization, ableism, and the enslavement of Black people. The unearned opportunities that I have as a white American come at the expense and suffering of many, and I am taking responsibility for this and for my role in upholding systems of oppression. As my own healing, freedom, and opportunities are intimately interconnected with those of every human and our planet, I do not come to save or heal or fix. I come to bear witness. A quiet daily recognition so different from the desire to replace. I strive to create a space where differences and queer expansiveness is celebrated, where collaboration breeds growth and healing, and where acts of resistance to assimilation and oppression are embraced, so we can have a new way of being can be imagined within ourselves, our patients, our profession, and our communities. So that's a little bit about who I am and what I'm bringing into my work and also into this session today. So now we get to begin. I'm going to start with a little bit of some theoretical knowledge around what is trauma and stress and the effects. And then I will then share some practical things that you can start integrating into your physiotherapy practice to embody a trauma-informed approach. And then we'll have a video case study to demonstrate how to apply some of these skills. So you can see the definition of psychological trauma on the screen. So it's witnessing or experiencing an event that is sudden, unexpected, or not normal, an event that's perceived to be life-threatening to yourself or to others. It causes an intense feelings of fear, horror, and hopelessness, and it overwhelms a person's ability to cope. And I just want to highlight that it can be experiencing an event or witnessing an event. When we talk about trauma, we also want to talk about and when we can you hear me? Come back. Sorry about that. So when we talk about trauma, we also want to talk about ongoing stress. So ongoing stress is a consistent sense of feeling pressured and overwhelmed over a long period of time. When it's chronic stress differs from acute stress in that it is lingering, pervasive feeling of being under pressure, overwhelmed, and it has long-lasting physical, emotional, and social effects similar to trauma. So as we talk about trauma and stress today, we're kind of really talking about both of these things because they are interconnected and they have shared effects. So we want to reflect now, what are experiences of trauma and stress that you think that people you work with, that you provide physiotherapy for, have experienced? So as I share about these different traumatic experiences and ongoing stressors, kind of reflect about who you work with and what you think they may be affected by. So you can see on the screen a variety of traumatic experiences. This is not a comprehensive, all-inclusive list, but it kind of gives you an idea. So you can see emotional, sexual, and physical abuse, serious illness, which obviously as physios we often work with, both serious illness in yourself or in a loved one. A life-changing injury, for example, spinal cord injury or amputation, is also an experience of traumatic experience. Healthcare experiences can also be traumatic experiences, as well as school discrimination or social discrimination when living with a disability, sexual violence and harassment. So I think as you look over that list, you can imagine that many of your clients are going through these different experiences, either have been in the past or are currently. And then we also want to think of the role of systems of oppression. The systems of oppression create ongoing stress situations for ourselves, our communities, and definitely our clients as well. So I'm highlighting here this article, which I really encourage all of you to take a look at, as it's specific actually to physiotherapy. So when we think of systems of oppression, we think of classism, racism, colonialism, ableism, heterosexism, cisgenderism, and sexism. So by living in societies where there are these systems of inequality, this can be an ongoing stressor. So specific to Canada, for example, 70% of trans youth in Canada have experienced sexual harassment. Or, for example, Black women in Canada face more systematic barriers within healthcare, as well as just generally in carrying out activities of daily living. So it's important to recognize that people you work with may have singular traumatic experiences, but they may also be living in ongoing stress due to the effect of these systems of inequality or systems of oppression. So I also want to just recognize that you may also have experiences of trauma and ongoing stress. And it's important for you to recognize that because that you also bring that into your work. You bring that into how you show up with clients and into, you may also have different social, emotional, and physical effects of it. So it's important to also recognize that in yourself, not just in clients. So now we know what is trauma, what's ongoing stress, what are some different experiences that can be classified as that. And now we want to think about what are the of trauma and stress that you may need to consider in your physiotherapy practice. And we can think of this from the biopsychosocial model. So there's physical effects, psychological or emotional effects, and social effects from trauma and stress. And these will show up in your physiotherapy. So one thing I really want to highlight is that trauma and stress causes physiological changes in our bodies. So it's not just psychological. It causes real changes in your brain, as you can see here, and it causes changes in our immune system, and our nervous system, and our cardiovascular system. So that can help us as physiotherapists understand why it's so important to understand and apply a trauma-informed approach. So I'm now going to ask Sean to play a video where you're going to see a little bit more content about how trauma and stress has physiological effects in the body. Go ahead, Sean.
Much of the infantile trauma is a very primitive survival part of your brain, and I like to call it the Oxford's brain. It's a part of you that just picks up those stages, says, but when you traumatize that little part of your brain, which is usually very quiet, continues to just send messages. I'm in danger. Feel safe. That event itself is over, but you continue to react to things as if you're in danger. We're talking about survival. We're talking about staying alive. So some people go into fight flight, or on a more primitive level, people's brain shuts down and they collapse. That these automatic responses are not a product of your cognitive assessment. They're a product of your animal brain trying to stay alive in the face of something that part of your brain interprets as a life threat. The problem then becomes that you are not able to engage, or to learn, or to see other people's point of view, or to coordinate your feelings with your thinking. Traumatized people have a tremendous problem experiencing pleasure and joy. But the core issue is our hormones and our physiological impulses that have to do with survival. Your body keeps mobilizing itself to fight. You have all kinds of immunological abnormalities, endocrine abnormalities, and that really devastates your physical health also. That the physical problems are longer lasting mental problems. The other thing that is terribly important is the impact of poverty, or the impact of racism, or the impact of unemployment. There's other societies that are much more trauma savvy than we are. But there is not the enormous amount of income inequality. Healthcare is universal. Childcare is universal. A culture like that really looks at what are the antecedents for certain forms of pathology. So the big issue is a political issue. How do we rearrange our society to really know about trauma so that people who grow up under extreme adverse conditions can become full-fledged members of society? So the community and being there for each other is a critical part of society. That's right.
Get smarter, faster.
Thank you, Sean. So the video highlighted one thing that I really like is how they talk about how the physiological impulse and hormones all geared up after a traumatic experience to fight. And I think that image can really help us understand what it might feel like to be living with the effects of trauma and ongoing stress. You can see here another slide kind of captures the effects of chronic stress and the effects of trauma. As you just kind of scan that, you really notice that there's a lot of things that might affect our physiotherapy interaction with someone. For example, chronic pain and headache, little or no memories, so their memories are altered, decreased concentration. You can also see the effects of chronic stress involve things like weight fluctuation, headache, irritability, dizziness, as well as things like increased risk of heart disease and heart attack. So all things that we care about as physiotherapists are often connected to the effects of trauma and stress. There's lots of studies to show that trauma affects pain. So many people with persistent pain also have high rates of traumatic experiences. So in other words, trauma and ongoing stress can contribute to persistent pain and pain-related disability. And then similarly, people with pain also can have symptoms of depression and anxiety. We also know from the Adverse Childhood Experiences Study, or ACEs study, that trauma is associated with higher rates of psychological conditions, non-communicable diseases, and poor health behaviors. Again, all things that we as physiotherapists have within our scope of practice to support, to prevent, to really address and think about when we're providing physiotherapy. I'm going to have Sean play 2 more videos. These talk about the ACEs study because I think it's an extremely important foundational concept for us to understand as physiotherapists. Go ahead, Sean.
It's something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC. And together, they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. 2 things. Number 1, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain and body stress response system that governs our fight or flight response. How does it work? In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma.
Hopefully that video really hits you and you can understand how the trauma and ongoing stressor really create physiological changes that are affecting our clients and our communities. And so then we want to think about, well, how are these effects of trauma and ongoing stress interconnected with physiotherapy? And I ask you to really sit and reflect with that. I'll give you a couple of my own ideas and the ideas that's supported by research and evidence. So one is it's going to affect the therapeutic relationship that you have with clients. So, for example, trauma often creates a disruption in a person's ability to trust people. So as a physiotherapist, we need to understand that and take different strategies and take more time to build trust with someone who may be experiencing the effects of trauma. Also, as we saw, trauma and ongoing stress are connected to a lot of the physiotherapy problems, symptoms, and chief complaints that we work with, like pain, cardiovascular functioning, sleep problems, movement disorders. And so similarly, it's going to affect our physiotherapy outcomes. It will affect a person's ability to participate in physiotherapy. For example, we saw that trauma and ongoing stress can cause low concentration or difficulty focusing. So then we have to think, as a physiotherapist, how can I support the person who might have difficulty concentrating? How can I change my education that I do to support them? We also saw how trauma and stress affects functioning in daily life, affects the person's ability to participate in meaningful life activities, and can ultimately contribute to disability. So the key point here is that as physiotherapists, we have the scope of practice and the responsibility to develop and utilize the knowledge, skills, and abilities to design and deliver physiotherapy treatment in a way that acknowledges the impact of trauma and ongoing stress. And if that's the only thing you take away from this session, that's enough. Because now from that foundational understanding, you can then work and find ways to develop the knowledge and skills and abilities to be able to do that. And I'll introduce you to a little bit of that today. And so I just want to emphasize, now you might be thinking, okay, I got it. What is trauma and stress? I understand it. I understand that there's effects that I need to think about, but maybe you might not feel that you're going to actually work with people who experience trauma and stress. I just want to show you a few statistics from Canada to really help you realize that majority of the clients that you work with will have had traumatic experiences and possibly have ongoing stressors and may be experiencing the effects of that when they're seeking services from you. So it's estimated that 76% of Canadians have had a traumatic event during their lifetime. And we also want to name that the missing and murdered Indigenous women is absolutely a traumatic experience for many of those communities that are affected, but also an ongoing stressor. And this trauma and ongoing stress not only affects the Indigenous community, but it affects all of us because we are all interconnected. And especially for you all as Canadians, you are interconnected with this Indigenous community and also have a responsibility for it. So it is a potentially traumatic and ongoing stressor for everyone. We can also see statistics about sexual assaults in Canada, as well as the pathway to justice in this. And again, we know that Black people of color and Indigenous people experience higher rates of sexual assault, as well as folks who are in the LGBT+ community. It's also estimated that about 8% of Canadians who experience a traumatic event develop PTSD. So we said that 76% of Canadians experience a traumatic event, and now 8% develop PTSD. And that's a diagnosable PTSD. So not everyone develops PTSD after a traumatic event, but in Canada, 8% do. And also some people may still have effects of trauma, just don't qualify under the PTSD diagnosis. We can also want to name and recognize the impact of suicide, as this is very connected to experiences of trauma and ongoing stress. And so 12 people in Canada die each day by suicide. And today, in this session, we'll also be giving you some skills to do a suicide risk assessment and to support and prevent suicide with your clients. And we never want to talk about suicide without providing the resources in case someone is in need of it. So just want to share that here. It's also in the handout, and I'll bring it back up when we talk about the case later today. So I just want to also encourage you now to think, if you don't acknowledge the impact of trauma and ongoing stress in your physical therapy practice, what do you think are the consequences? What do you think are the consequences if you don't embody a trauma-informed approach? So I just encourage you to think about that, talk about it with your colleagues. From my perspective, I think about how, one, if we don't embody a trauma-informed approach, then people will continue to suffer because we won't be able to provide care for folks in a way that's actually effective. It gets outcomes that help maximize their participation and function in life. Additionally, if we don't provide trauma-informed care, then we potentially are not preventing suicides that are preventable. And then also, I think a lot of you probably work in private practice. And so you're often thinking about making sure you have clients and that clients are coming for the treatment sessions that are recommended from a profit perspective, which I can understand. So if you think about it, people who have effects of trauma and stress, if you don't have a trauma-informed approach, most likely a lot of people won't come back for the treatment sessions. So a way to, if you embody a trauma-informed approach, most likely your adherence rate to the treatment plan, treatment sessions will be better, and hence your ability to loss of future. So hopefully you're like, okay, I got it. And it's important to acknowledge the impact of trauma and ongoing stress in our practice. So you're like, how do we actually do that? So now that's the remainder of this session. We're going to touch on different knowledge and skills to support you to do that. And this is really an introduction. And so we're just touching on some knowledge and skills that you can immediately use in your practice. It's safe for you to use, but I really do encourage further learning and development in this area as well. So the way we do it is a trauma-informed approach. So a trauma-informed approach, as you can see here, is a clinical framework that involves understanding, recognizing, and responding to the effects of trauma, as well as ongoing stress. You can see here the principles of a trauma-informed approach. This is a very well-established approach, so I provide resources at the end for you to learn more. And it's not just recommended for individuals to do, but it's actually recommended that all organizations that work with people should have a trauma-informed approach. So all healthcare organizations should have a trauma-informed approach. This should be reflected in their policies and procedures and clinical services, both trauma-informed for clients that are accessing a service, but also for the staff. So I just want to recognize that a trauma-informed approach is quite large, and there's really a lot of opportunities for us to strengthen it within our physiotherapy profession. So today we're going to be focusing on two of the principles, the ones highlighted there in yellow. Recognize the signs and symptoms of trauma and stress, and apply the knowledge of trauma and stress and path to recovery. So first, we're going to think about how do we apply the knowledge of trauma and ongoing stress and path to recovery. Well, first, we need some knowledge to be able to apply it. I'm going to offer some different knowledge, some key pieces of knowledge today. And what I ask you to do is I'm going to have a statement on the screen, and then I'm going to have you think about, is this statement true or false? And if you think it's true, you're going to put your hands on your head. If you think it's false, you put it on your chest. And even though I can't see you, what I encourage you to do is still do the physical movement as we go through this, because we know physical movement enhances our memory and learning. So you're going to be more likely to remember this information if you pair it with this movement. So that's why I encourage you to do it as you're listening along. Okay, so first statement. The effects of trauma are permanent and will always affect a person's life. So if you think it's true, put your hands on your head. If you think it's false, put your hands on your chest. So this is false. Effects of trauma are not permanent. They won't always negatively affect a person's life. So you can see some pictures there that kind of put this into images. But we as humans, and we know this from lots of research, are really inherently equipped with ways to make meaning from trauma and stress, and to really learn how to integrate it into ourselves so that it will no longer be overwhelming, that it will no longer affect our lives negatively, or will no longer contribute to disability. The effects may still be present, as you can see on that picture on the left, where the impact of trauma is still there, but it's smaller. And it's just a part of yourself now. So it's really important to recognize that the effects of trauma are not permanent, and there are paths to recovery and to fully participating in life. Okay, next statement. Think about if this is true or false. The effects of trauma and ongoing stress can be passed down into a person's children. So this is true. You may have heard of this term, intergenerational trauma. There's lots of research to show how experiences of trauma and ongoing stress can be passed down genetically into children. But importantly, you can also, you can see on the statement on the bottom of the screen, when you work on your trauma, you choose to not pass it on to the next generation. So we also have an ability to not just heal ourselves, but to also heal the future generations, which I think is pretty cool. And there's lots and lots of research on this if you want to. Okay, next statement. Many people experience positive psychological change after a traumatic experience. Think for yourself and move your hands. Do you think it's true? Or do you think it's... So this is true. The scientific term for it is post-trauma growth or post-traumatic growth. So lots of research has shown that we actually can have a greater appreciation of life after trauma, have closer relationships. But there's lots of positive changes that can come from traumatic experiences. So next statement here. If a person is experiencing effects of stress and trauma, their fault, and is a sign that they are weak and not resilient. So think for yourself, true or false. Okay. So this one is false. So I think most of you probably said, yeah, that's false. I got that. But it's not a sign that someone's weak. It's not their fault. I think we cognitively believe this, but sometimes this bias can be kind of underlying in ourselves. It can actually then be kind of an implicit bias. And so it's really important to really sit with that and think, is this do I actually have this belief, and is it affecting how I show up with clients? Maybe that I label them as non-adherent or uncompliant, and that I'm not as empathetic when they're having effective trauma. Couple more statements here. The next one, on average, 7 out of 10 people recover from the effects of trauma without professional support. Again, think true or false. So this is true. So most people, 7 out of 10, when they have a traumatic experience, actually recover. They have acute effects of trauma, but they recover and go back to living their life fully without any significant problems after about 3 to 4 months, without any professional support. Most people do that by connecting to their loved ones, by feeling supported, by having different protective factors in their life. So I think it's also helpful to understand that, so you can also educate clients about that, and also recognize when to prioritize professional support. But often it's most helpful if someone really hasn't recovered after a few months. Next statement. If a person avoids thinking about the traumatic experience or ongoing stressors, it will not affect their body, thinking, and behavior. True or false? So this is false. Avoidance is a coping strategy. So our brain automatically does. Our brain and our body does it to protect us. So avoidance is a common strategy to trauma. And you can see here that we actually think of PTSD as a disorder of avoidance. So it's a continuous pattern of avoidance that is protective, but it's preventing a person from living and engaging in a full life. Maybe it's kind of similar. You can think about the fear avoidance cycle in pain, if you're familiar with that in our physiotherapy practice. So the same thing applies to trauma. If we do a fear avoidance cycle within the traumatic experience, it can contribute to greater and greater suffering and problems of function. But on the side, within that, it's important to recognize that avoidance is protective. And so it can be very harmful to push someone to stop avoiding the traumatic experiences unless you have the skills to do that. So really that's where counseling and skilled mental health providers can go alongside with someone to address avoidance in a healthy way. But it may not be our role as a physiotherapist to do so because we might not have the skills to do that safely with a person. I think this is the last statement here. Allowing a person to tell you about their traumatic experience and ongoing stress will always be helpful in healing. Do you think this is true, or do you think it's false? So this is false. It can actually be harmful to allow someone to tell their traumatic experience and ongoing stress because the re-exposure, as they tell you the story, can activate the similar flashbacks. It can increase symptoms or effects of it, and it can also cause what we say is re-traumatization. And it can also strengthen avoidance patterns. So really, as a physio, it's important to have skills to contain when someone starts to share about the traumatic experience and ongoing stress, to contain it in a healthy way to support that person's health, and in a way that the person feels trusted and feels supported as well. So that is one of the skills of the trauma-informed practice. Okay, so after all of those different facts, you might have different questions about those statements that we read. So if you do, please, as Sean said, put it in the Q&A and we can address it at the end. Okay, so as I said, we're focusing on these 2 principles of a trauma-informed care approach. And so we can see on the left, recognizing the signs and symptoms of trauma. This really involves, we're going to talk about the skill of screening for depression, PTSD, and suicide risk. So that's the skill that I'm going to offer you today. And then from that, once you recognize that a person has signs and symptoms of trauma or stress, then you can apply the knowledge of trauma and recovery, which I'm also going to address today. So I'm going to offer some practical clinical tools and skills you can really start using in your clinical practice, and we're also going to do a video case study to apply those skills. So first, we want to understand what is post-traumatic stress disorder, and then we'll talk about how do you screen for disorder. So you can see the talk, how do you screen for PTSD within your physiotherapy? Go ahead.
Okay, April's audio is cut out, so we're just going to start in with the video.
Experiencing or seeing something traumatic can be a really tough thing to work through, but after a while, most people settle down. If they're still having trouble after 6 months or more, post-traumatic stress disorder may be considered. All sorts of traumatic experiences can cause PTSD. For children and young people, it's usually something like a car accident. It could also be any number of other things, such as physical or sexual abuse, family violence, or the death of a loved one. While the causes are varied, it's important to remember that PTSD is not caused by media such as movies, books, or video games. Whether they have witnessed a trauma or were directly involved in it themselves, kids with PTSD will usually have increased feelings of anxiety. They might relive the trauma through nightmares or flashbacks, or even try to avoid anything that reminds them of the experience at all. Any of these symptoms can seriously get in the way of a young person trying to live his or her life. It can sometimes be hard to tell if a young person is suffering from PTSD. Some common signs are difficulty sleeping, distractibility, poor concentration, nightmares, intrusive memories, or difficulty following his or her normal routine. Addressing and managing PTSD in children and youth starts with patience and understanding. Create an open atmosphere so they feel comfortable talking about their feelings. When they do talk, be an active listener. They need to know that their feelings are being accepted and not judged. This can be hard if the adult has also lived through the same trauma, but establishing an open line of communication is essential for the young person's well-being. Young people coping with PTSD should be encouraged to resume their normal pre-trauma routines. This should be done carefully and with consideration to their emotional state. Gradually returning to normal life is an important step in processing and moving on from the trauma. Managing PTSD is an ongoing process and may take time and patience. In the months and years following the trauma, different situations may trigger trauma feelings in new and unexpected ways, and a child might not be able to recognize that what he or she is feeling is connected to the trauma. So as the adult, it's important to be prepared for these relapses. More detailed information around all of these strategies can be found in the links below this video. A personalized My Anxiety Plan, or MAP, can be built by watching our orientation video and using the guide. Or download the MindShift app and try some of the chill-out exercises.
Great, thank you. So you can see there that video really focused on youth and PTSD, with a lot of the same concepts applied to adults as well. So PTSD, as we saw in the statistics, 7% of people who have experienced a traumatic event will develop PTSD in Canada. So it is likely that folks that you see in physiotherapy, a percentage of them will have symptoms or effects of PTSD. So it's important to screen to make sure that people are necessary support. So you can use the primary care PTSD screen. You can see it here. It's very simple, probably very easy to add to your intake files or intake forms that you have the person complete before treatment. So I just asked, in your life, have you had any experiences that were so frightening, horrible, and upsetting that in the past month, so that time frame is important, you had nightmares about it or thought about it when you did not want to, tried hard not to think about it, or went out of your way to avoid situations that reminded you of it, constantly on guard, watchful, or easily startled, felt numb or detached from others, activities, or your surroundings. And the key there is that those effects are in the past month, not necessarily the traumatic event. So they say yes or no to those questions, and if it's I think you can hear me again. Sorry about that. So if a person answers yes to any three items, then it's a positive response for possibly PTSD. It doesn't mean that they have a PTSD, but it does mean that you should consider referring them to a mental health professional to support them through this. So in addition to PTSD, we want to think about how do we screen for pain or for depression and anxiety, because we know that it's very common effect of trauma and stress, but it's also very common with people who experience persistent pain. We know from research that as physiotherapists, we are not good at screening for symptoms of depression. You can see the study here. One, that we often don't use the formal depression tests that that are available to us, and that sometimes as physios, we are like, I'll notice when someone's depressed, but we actually don't. This research shows that. So it's really important to use a objective tool to screen for depression. So you can use the PHQ-2 here, which is just these two questions. Again, very easy to integrate into an intake form. So over the past 2 weeks, how often have you been bothered by any of these problems? 1, little interest or pleasure in doing things, and 2, feeling down, depressed, or hopeless. And then just score it from 0 to 3. And then you add up the total score for those two questions, and if the cutoff score is 3. So a score of 2 or less is a low likelihood of depression. 3 or higher means that you should really consider a referral and to understand that this person may be experiencing effects of depression that you want to consider in your physiotherapy treatment plan. So also, when you have a score of 3 or higher on the PHQ-2, it's recommended that you assess for risk of suicide. So you can do that in a variety of different ways. So first, you want to definitely assess for risk of suicide, which we're going to talk about here. And then you can think about some other next steps. If they have a score of 3 or higher, you can use some other questionnaires like PHQ-9. You can use the depression, anxiety, stress scales. You can consider keeping and referring to a mental health professional. You can also just refer to a mental health professional and not keep them with physiotherapy, or you can monitor and reassess it and see if progress is poor, then you can consider referring to a mental health professional. So those are all different options if a person scores 3 or higher on the PHQ-2. But you always, always, always assess for risk of suicide if they have that higher score. That's what we're going to talk about today. So when we think about assessing for risk of suicide, many of you may never have been introduced to this skill set. It was something I developed outside after physiotherapy school, but now I do it very regularly. I probably assess for suicide just a couple people a week because of the type of setting that I work in. It might not be as often if you're in a different type of setting. So first, the question is, when do we assess for risk of suicide? So you can see on the screen here all the different reasons you might do that. So if they positive screen for depression, so if they screen positive on the PHQ-2, you do. If they have a positive screen for PTSD, so if they have positive screen on the PTSD screen, you assess for risk of suicide. Your clinical judgment, if you just feel like, I'm noticing some things, they maybe made some comments, it's okay you can go forward and assess for risk of suicide. If they have a diagnosed behavioral or emotional disorder, it's important to assess. So that could be diagnosed anxiety, depression, PTSD, also could be things like bipolar disorder, or ADHD, or panic attacks. Those are all things that really indicate a higher risk of suicide and that you should assess. And then if there's any comments indicating risk, so if anyone talks about hurting themselves, feeling hopeless, feeling depressed or worthless, then it's really important to do this assessment. And you can see here that often this quote is specific to primary care doctors. They rarely assess people for suicide, but I think it applies to physios as well. And often the reasons they're not doing it is similar to the reasons we might not do it as physios either. Because we feel uneasy at starting a conversation with a patient about suicide. Maybe we don't know how to do the suicide risk assessment, or we don't feel confident. Okay, if someone does have suicide risk, what do I do then? So today I'm going to hopefully help you feel a little more confident in doing this, give you a script and a tool to talk about suicide risk assessment, and then help you start to think about how do you actually address if people do have a suicide risk assessment within your context. And I just want to emphasize that we know confidently from lots of research that talking about suicide does not increase the risk that someone will commit suicide. It's a very common myth, but it is not true. So it actually saves lives to talk about suicide. It saves lives to do suicide risk assessment. So we're going to talk about how do you do the suicide risk assessment here. So you can see this graphic. It represents how you can approach a suicide risk assessment. You start on the left with talking about thoughts of death, and then you progress along to then talking about a person's intent. And after you gather all the details, you then decide, is the person at a high risk, medium risk, or low risk? So I'm going to show you now how you actually carry those out. So first you have to introduce the topic. And each person, each physio is going to have your own style of doing this, and that's fine. I give you some open-ended questions here that can kind of help introduce the topic. At first, it's important that you normalize the situation by saying things like, a lot of people that I work with have thoughts of suicide, and so I would like to just ask you some questions about that because I care about you and I want to make sure that you're safe. And then you can ask different open-ended questions like, do you think about killing yourself? Do you have thoughts of death or wishing you were dead? Have you ever felt like hurting yourself, or wanting to kill yourself? If a person says no, then your suicide risk assessment's done. If they say yes, then it's important to gather a little bit more information. Here are some questions you can use to gather information. For example, when and how often do you think about it? Do you have a plan for killing yourself? If yes, what is it? What would you use to kill yourself? Do you have access to that? How would you gain access? And have you ever tried to kill yourself before? Yes, what are the details of it? And so based on all the information you gather from that conversation, you then decide, is this person at a high, medium, or low risk? And you can see in the table there how to determine that. Based on the risk, then you say, then you can see the possible interventions as well. So high risk is really immediate hospitalization, and you're not leaving the person alone. And low risk is an outpatient referral, and a medium risk is kind of dependent on the what resources you have available, but definitely doing a safety plan or a crisis plan. And to help understand how do you determine if it's low, medium, or high risk, you look in that middle column about suicidality. So low risk is someone has thoughts of death, they don't have a plan, they don't have details of how they would do it or intent to carry it. Medium risk is they have thoughts of suicide and they also have a plan, so they can say specifically how they have thought about doing it. That's a medium risk. And then a high risk is that they have attempted or they've rehearsed it out, or that it's a very persistent thoughts and plans that go through their head. So this is the same content in the table, just written out in a different format. So I just wanted to offer that for you. And then similarly, as you would have seen at all levels of risk, if it's low, medium, or high, you always give the suicide crisis hotline information. So this is the one specific to Canada. So I'd really recommend that you have it available in your physiotherapy setting for handouts, so you always can make it known, and also have it be in places where clients can also pick it up without it being handed to them. Okay, so we talked about now how do we screen for depression, PTSD, and suicide risk. So you know how to recognize at least some signs and symptoms of trauma. And then when you do recognize that, you have to apply the knowledge of trauma and path to recovery. So to do that, you can do a few things. One is you think about how are you going to adjust your physio treatment plan to acknowledge that this person is having some effects of trauma and to acknowledge that they're having depression, PTSD, and suicide risk. I think sometimes we can, as physiotherapists, say, well, that's not our responsibility, just refer to mental health. But in reality, often we do have a role and we have a scope of practice and skill set to modify our physiotherapy treatment plan in a way that can be effective for people who are experiencing trauma, stress, depression, PTSD, and suicide. But it's outside the scope of this session to really talk about that. But it is part of learning and strengthening trauma approach. And then also what's important is understanding how do you implement procedures for suicide risk. So what do you do in your setting if someone has a high, medium, or low suicide risk? And how do you make referrals for mental health professionals, whether it's for depression, PTSD, suicide, anxiety, etc. So I can't really tell you exactly how you implement procedures for suicide risk or for mental health needs, because each context is so different. What I'm offering here is some ways to think about it. So in your context, in your workplace, for example, for managing suicide risk, you can think about and ask your team members and your leadership, what are the referral pathways, sources, and procedures specific to suicide? What do we do? What's our policies and procedures for this? In an emergency context, so if someone's high or medium risk, what do we do? And in a non-emergency, if someone's low suicide risk, what do we do? You can also ask, is there training available for me to learn more about risk assessment and how to develop safety plans for suicide? You can ask, is there a key clinician in the organization to support situations of risk? This is really important. Is there someone, when someone has a suicide risk, that you can call that has the skills and experience to kind of talk and guide you through what to do next? Maybe it's a mental health person or someone just with more experience, but really someone who's signed as that focal point. And then is there a collaborative care model in place specific to suicide risk? So a collaborative care model is a best practice recommendation in relation to suicide risk. So that's why it's to ask, and ideally all organizations do. But I'm assuming a lot of workplaces that you're working in will not have answers to these questions. So if they don't, I really encourage you to work with your organization to develop them, because this saves lives. Okay, so we have knowledge now and some skills. So we want to think about how can we apply it. So what we're going to actually do is a choose your own adventure. So we're going to have a case example. And as we go through the case example, you'll hear videos from the client and myself, and you're going to be able to decide if you were a physiotherapist, what would you do in this situation? And then we'll see the outcomes of those different choices. So our client today, you can assume you're working in a private practice physiotherapy clinic. This client comes in. His name's Tom. He's 21 years old. He is a college student. He has no past medical history. And he's coming into you direct access just to come to see you for his physiotherapy needs. And we're going to say, you're starting your assessment, you're sitting down with Tom, and you say, Tom, what brings you here today? I'm going to have Sean play the video of Tom responding to that question. As you listen to Tom's response, I want you to think how would you proceed as a physiotherapist in this situation? And just to note, Tom is not a real client. He's a friend of mine, also a PT, who recorded this. I think, Sean, you might need to play it again. I couldn't hear the audio.
Okay.
Just waiting for you to play it again there. See if we can hear it this time. Still not hearing it.
Sorry.
I can hear you. No.
Headache for the last month or so. It's been really bad. It gets worse when I try to read. So right now, while I'm falling way behind my classes.
Thank you. So as you would have heard Tom, he said he has neck pain and he's falling behind on classes. So if you're the physiotherapist, you can think, would you do A, ask Tom if he has any additional symptoms or problems, or B, proceed to the subjective and objective examinations for headache and neck pain? If you want to put your answer in the chat, you're welcome to. So think, as a physio, would you just go, okay, he has neck pain and headache, let's do the subjective, objective examinations for that? Or would you say, does he have any other symptoms? So if you had said B, you're just going to go on and do the examination, you would have found increased muscle tension in the face and neck, mild limitations in active range of motion of the neck, tenderness to palpation in the neck musculature. So you would have recommended some standard treatment for these complaints, come in for a few sessions. But what would have happened is Tom does not follow your recommendations. He doesn't return to see you. And you assume, he was young. He's probably just got better. He's probably fine. But if you would have chosen A, which is the more trauma-informed, you would have asked Tom if he has any additional symptoms. So now you're going to see the video of me asking Tom about that and Tom's response. As you listen to Tom's response, I want you to think if you notice any possible signs and symptoms of trauma or stress that you need. Go ahead and play.
Sounds like it's been really difficult for you, especially with keeping up with classes and everything. I work with a lot of other college students like you, and I find that in addition to having pain, they often have other problems or other symptoms. For example, some have poor appetite, problems sleeping, upset stomach, constipation. Are you experiencing anything like that?
Yeah, I guess. Can't sleep. Takes me forever to fall asleep. Used to be able to sleep anywhere now. My stomach's off too.
Okay, so you said you're having problems falling asleep and that your stomach is off. Can you tell me a little bit more about your stomach?
It just feels tight. Can't eat very much. And not really use the bathroom very often.
Okay, I understand. And then you said you have headaches is the main problem. And I know that many people with headaches have problems concentrating or focusing or feel tired all the time. Are you having anything like that?
Yeah, I'm always tired. Probably because I'm not sleeping. Concentrate in class. My head hurts and I can't focus on what they're saying.
Okay. And all of these problems started about a month ago, you said?
I was doing fine before, at the occasional headache, but it wasn't yeah, it's a bit of
As you listen there to Tom, you can think about, are there any possible signs and symptoms of trauma? And this is one way to embody a trauma-informed approach, is to train your listening ear and your brain to notice those things as people are telling you about their experiences and their story. So with Tom, you could have hopefully noticed some possible signs and symptoms of trauma. So one is an insidious onset of these symptoms with no past medical history. He said, it's fine before. He has multiple somatic complaints, neck and headaches as well. Fatigue, he talked about poor concentration, sleep problems, upset stomach, low appetite, and changes in bowel habits, meaning the constipation. So all of these could, as a physio, when you hear that, be like, maybe there's something related to trauma is what's going on here, not just a musculoskeletal situation. So based on what Tom just shared with you, and think about your own adventure. What would you do as a physio? Would you A, provide your standard treatment for headaches and neck pain? B, screen for depression and PTSD? C, perform the suicide risk assessment immediately? Or D, refer immediately to a mental health professional? So think for yourself, would you choose A, B, C, or D? So if you chose A, you provide your standard treatment for headaches and neck pain right then and there. But again, Tom wouldn't follow up. He wouldn't come to the next treatment session. You just assume he's probably better since he's young. If you chose C, perform suicide risk assessment immediately. So this is appropriate. It means that you picked up on some indications of risk, which is great. However, it might not be the most effective next step. It might be more worthwhile to first screen for depression and PTSD rather than jumping right into the suicide risk assessment, because this can help build your therapeutic relationship or alliance with Tom. And also knowing if there's any signs of depression and PTSD can also inform your suicide risk assessment. So it'd be better to kind of wait a little bit to do that one. So if you chose D, refer immediately to a mental health professional. Again, it's great that you appropriately recognize possible signs of trauma and emotional problems. However, it's going to be better to first screen for depression and PTSD before just immediately jumping to a referral. Because one, if you screen, you have a little bit more information to make that informed clinical judgment about the referral. You can also make a more informed referral. You can give the referral source more information. And also that process, you can use that process and that information to educate Tom about why the referral might be supportive. And then also it can ensure that the suicide risk assessment is completed if indicated. So you don't want to just jump to referral. You also want to make sure that you can do the suicide risk assessment if needed. So the best, most effective approach would be to next screen for depression and PTSD. So you're going to hear the video now about how I asked Tom to do the actual screenings with the PHQ-2 and the primary healthcare PTSD screen. Just how to approach it with him. So go ahead and play that video.
I want to make sure that I understand you and your problems completely, and I have two short questionnaires that I often use with clients that I find really helpful. They do have some sensitive questions on them, but is it okay if we do them together?
So that's just an example of how to introduce using the questionnaires, because sometimes we can feel a little uncomfortable or not confident in how do I actually bring these topics up to clients. So I was just role modeling how to do that. So if we then look at what are Tom's results on the questionnaire. So on the PHQ-2, you can see Tom answered 2, so more than half the days in the last 2 weeks. He has little interest or pleasure in doing things. And then you can see he said 3, so nearly every day in the past 2 weeks, he feels down, depressed, or hopeless. So that's a total score of 5. And then in the primary care PTSD screen, you can see he answered yes to 3 of the items. He said yes, he has nightmares about it or thought about it when he did not want to. He tried hard not to think about it or went out of his way to avoid situations, and he felt numb or detached from others. So based on those 2 screening questionnaires, you then think, next best thing, is it A, to assess risk of suicide, or is it B, the next best thing to refer to a mental health professional immediately? So if you said B, refer, so it is appropriate based on the results of those two screening tools to refer to a mental health professional. But first, you have to assess Tom's risk of suicide. You do not want to let Tom leave your office without assessing risk of suicide, because that can save his life. So the best thing is to really move forward with the suicide risk assessment. And we also consider that Tom's a college student. And so we know based on research that 4 out of every 5 college students contemplate or attempt suicide when they show warning signs. So Tom might be showing you a warning sign, and it's your responsibility to recognize those warning signs and then conduct an appropriate suicide risk assessment. So next step is to assess risk of suicide. As we talked about, we kind of go through this progressive asking of questions where we talk about thoughts of death, suicide ideation, plan for suicide, means available, and intent. So the next video, you're going to see my conversation with Tom that involves how do I assess for risk of suicide. And you'll notice that my questions kind of progress along this graphic, going from thoughts of death all the way to intent. So go ahead and play that video.
Thank you for sharing all this. I really appreciate it. And it sounds like you're going through a really difficult time right now. Can you tell me, have you ever had any thoughts about killing yourself?
Yeah, I guess.
Okay, I work with a lot of people that have those thoughts, and I want to understand it better so I can help you. Can you tell me how often you have these thoughts?
About a night. Most nights.
Okay. Have you thought about how you would kill yourself?
Probably with a gun. Want to be quick.
I understand. Do you have a gun?
Yeah.
Do you know how you could get a gun?
I guess I could buy one.
Do you have any plans to do that?
Oh, no, not really.
Okay. Can I ask, have you ever tried to kill yourself before or had any similar experience like this?
Never felt like this before.
That was an example of the conversation you can have to assess risk of suicide. You could have hopefully saw how it progressed from thoughts of death to intent. So based on the information that Tom offered us and shared with us, then we think, okay, is Tom at a low risk of suicide, medium risk, or high risk? So think for yourself, what do you think is Tom's risk of suicide based on what he shared with you? So hopefully you could identify that Tom is at a moderate risk of suicide. That is because he has suicidal thoughts. He shared that with you. And he has some plans. So he talked about that he did think about that he would use a gun, but that he does not indicate intent, meaning that he hasn't really thought about how to get one, who has one, how he has access to it. And he hasn't shown any behavior that indicates he's planning to act on it. So he's at a medium risk. So then we have to think, based on medium risk of suicide or moderate risk, what's the next best step? Do we A, provide Tom with the suicide prevention phone number and schedule an appointment with Tom in 2 days to follow up? Or B, discuss an action plan or safety plan with Tom to keep him safe? So based on a medium risk level, is it an A or a B? So if you said provide Tom with the suicide prevention phone number and schedule an appointment with Tom in 2 days to follow up, this is not enough. As you can see, with a medium moderate suicide risk, which is what Tom has, you can see the possible interventions are admission may be necessary depending on risk factors, develop a crisis plan, and give emergency numbers. So really, if you decide to just schedule an appointment with Tom, then you're really putting Tom at risk. So the next best step is to discuss an action plan, sometimes called crisis plan, sometimes called safety plan with him. It's outside the scope of this session today to talk about the details or to up-train you on how to do a safety plan, but we're going to play the video now so you can see me working on a safety plan with Tom. So go ahead and play that video.
I understand that you're struggling right now and having suicidal thoughts. and I want to work with you to keep you safe. Is it okay if we just set this aside right now? Okay, so we're going to write down a plan together. And the first step is often identifying a family member or a close friend who can help support you. Can you think of anyone who could do that?
All my parents. I just really don't want my friends to know.
Okay, I understand. I think it's a great idea to call your parents. I'm going to put that down as number one. And I don't see why your friends would need to know anything. And the second point is that often people will find it helpful to see a counselor. Counselors specialize in helping people with suicidal thoughts. And often counseling can help with other problems that you have, like fatigue, headaches, sleep problems. Sometimes when we are emotionally overwhelmed, our body reacts by having pain and headaches and all these other problems. So counseling can really help. Would you be open to me referring you to a counselor?
Yeah, I really don't want my friends to know. I just really don't want to deal with school.
Okay, I understand. We can refer you to a counselor outside of the school. I'll put that down for number 2. So a counselor, but outside of the school. And do you think there's anything else that will help you? Is there anything else that you could do to stay safe?
Maybe I should just go home for the week. I don't want to be at school and live there and get really focused. That
sounds like a really good idea. I'll write it down. So you can, if you talk to your parents about going home with them, what you call them. And so now we have 3 things. We have 1, call your parents and ask them for help. 2, see a counselor. And 3, go home with your parents for the week. Does that all sound okay and clear?
Yeah.
Okay, if we do this plan, do you think that you can stay safe for at least a week?
Yeah, I think so.
Okay, that's really good. I'm really happy that we found a plan that you're comfortable with. The last thing that I want to share with you is the phone number for the suicide prevention hotline. You can call it at any time. So if you feel overwhelmed emotionally or you feel like you can't stay safe, you can call this number and I can help you. So the number is going to be on the paper with all the other people. Is that clear?
Yeah.
Great. So there you saw a conversation of how to develop the action plan or safety plan with Tom. So, and the story or adventure with Tom. And so with the support of Tom's parents, he was able to implement the safety plan. He was able to have counseling, and he was able to regain control of his emotions, and his physical problems gradually improved to full recovery. At the same time, he was able to also participate in physiotherapy with you. So you can also support the physical challenges that he was experiencing as well. So this case example is based on the fact that Tom had experienced sexual violence or sexual assault. Now, as you were going through this process with Tom, you never actually knew what the traumatic experience with Tom was. And you didn't have to provide quality care and to support him and to do a suicide risk assessment and screen for the different challenges and make referrals. So that's important. You don't always have to, and it can also be harmful to ask directly about the traumatic experiences that may be contributing to the symptoms that you're seeing. So that comes to the end of our session. We're going to take questions and reflections, and I just want to share that you have in the handout different resources so you can continue to learn more about this and continue to develop your skills in a trauma-informed approach. So I'm now happy to open it up to any questions.
Thanks very much, April. That was a great presentation, and I really like the practical application that you're able to bring. So I think one question that came in was, how can a PT identify when it is safe or appropriate to allow for the retelling of trauma? And how can you know when it is safe, when it is not safe to do so, or would potentially result in re-traumatization? Or is it always about having skills to contain that discussion before you enter into it with the patient? So kind of a few questions kind of built in there, but kind of takes it through.
So I think the first question is, how can you know if it's safe for the person to tell you about their trauma or their stressors? So often, if you notice that a person has effects of trauma, just like tongue, for example, then you can say it's not safe. I'm not going to open that. I'm not going to initiate that. If they start to tell me, I'm going to contain it. Second way to kind of assess that is if a person starts telling you their story and you notice signs of dysregulation, then it's not safe. So signs of dysregulation can be, you can either have hyperarousal, where the person's really active, they're moving their body, they're talking really fast, they're not making eye contact, and I'm kind of mimicking it now, but they just keep it's almost like they're on a loop. They push play, and that they're not able to really engage with you while they're telling the story. And it's no longer discussion, but they kind of just like blurting it out, for example. Second signs of dysregulation is kind of that numbing or shut off. So low energy, they're not making eye contact as they tell you the story. Again, they're really not responding to you. They're just in their own body and mind as they tell you. So those are signs that, like, okay, this is not safe, I'm going to contain. And then was the second question, Sean, like how to contain? Is that correct?
Well, yeah, and then the second one is, I guess, if you're starting to see those signs, how do you, I guess, kind of contain that discussion, or do you need those skill sets and need to have those skill sets available before you actually start entering into these discussions with patients? Is there any things that you can do if you do see things going sideways that you can kind of bring the conversation back, get the patient to I guess kind of come back down to a baseline level where then you can kind of continue on with the discussion in a different direction?
Yeah, great. So if you start to notice those signs of dysregulation, that maybe it's not healthy what they're sharing, or helpful for them to share in that moment. So one thing is you can interrupt them. Often we think we shouldn't interrupt people, but in this case, it is the most safe thing to do. So you can say, can you pause a second? I'm going to interrupt you. And then you explain why you're interrupting. You're saying, I can tell you're getting a bit stressed as you tell me this. And, it's really not necessary or helpful for you to tell me all those details. I understand it sounds like you're going through something really difficult, but I might not be the best person for you to share that with me right now. So if it's okay, let's go back to what we were doing, whether that's, let's go back to the assessment and we can kind of stay on the structure so I can really help you with the problems that you're coming to me for. Or can we go back to the treatment that we were having planned today because I know that you want to work on this thing that you told me about before. So kind of interrupting them, but in a way that shows empathy and helps them connect with you. And then also, oftentimes when someone's dysregulated, they will have a hard time coming back to whatever you're trying to focus them on. So that's a good time to do some breathing, some diaphragmatic breathing, or some calming movement, or a grounding breathing relaxation technique. So there's different skills that we have as physios within our scope of practice that we can also utilize in that moment to kind of support the person's regulation.
Yeah, and I think that, that answers that quite well. I think we just have one other quick one, just keeping in mind the time that we have. So basically kind of what we'll go through, what the question was when patients are showing signs of trauma, and I think what you went through today was a lot about that initial part of recognizing and addressing it kind of with the patient. But then how do you bring it back to the actual PT assessment and treatment, and then get them to potentially, buy into how, movement and exercise could potentially be helpful physically and emotionally?
Nice. Yeah, so we know that, right, our physical and emotional health are connected, like you just named. So a lot of times I do education with people to help them kind of make that conclusion for themselves. So for example, we can ask the person, okay, when you're feeling really stressed or upset, what does that feel like in your body? And most people can usually tell you, I feel really hot in my body, or my shoulders get really stiff, or my stomach gets upset. So by them kind of thinking through that, say, okay, so you can see how our emotional health affects our physical body. So it can also do the opposite. We can also use your physical body to positively affect your emotional and mental health. And so having that kind of education moment, and then also giving them opportunities to experience. So for example, with a lot of clients, I start with a relaxation technique. Help them notice what do they feel before the relaxation technique, and then what do they feel after. And them experiencing that effect in their body, then they say, oh, wow, it feels so much better. You can see how this kind of is going to help me. And then linking that to whatever this other physiotherapy problems you're working on. So if it's shoulder pain, shoulder tension, again, doing an intervention to help them notice the changes in their body, also the changes in their emotions in their mind. Really just guiding them to notice how different things affect them.
Awesome. Thanks very much, April. So yeah, that's the end of question period. So once again, I just really want to thank you for taking the time to prepare this webinar, and the content was, I thought, quite fantastic. So once again, a huge thank you to you, and I hope those that tuned in were able to get a lot out of today's session. As a reminder, the handouts are available for you to print off, and the webinar will be posted on our website and our YouTube channel within 2 business days.